Dr. Sweeney, we're going to start with you. Tell us about yourself and your work, and uh, start answering or try to answer. I actually know you do have an answer to Orla's question. Dr. Sweeney.
Well, thank you very much. Um, First, thank you, Orla, for the really kind introduction. And of course, it's an organization and a cause that's near and dear to my and our hearts at Inflammatix. Maybe for everyone, my just a personal introduction. My background was originally in clinical medicine. I trained in general surgery before starting to do some research into better understanding critical illness like sepsis, and eventually founded a company called Inflammatix, which has brought a novel diagnostic tool to market called TriVerity. And we were asked to present a few minutes of slides on these diagnostics, and I'll see if I can answer Orla's question here, maybe with just a brief presentation. I think that the right question is, in many ways, as you'll see, not so much can we find patients with obvious sepsis today. And if we think back to Rory's story, right, that initial fall and scrape with dirt in it, that didn't start as sepsis. It started as a mild bacterial infection. And when we think about sepsis, maybe in the presentation to the emergency department, there are a lot of really important sepsis alert tools, whether they're, sort of traditional SIRS criteria or EPIC sepsis modules, or really cool new tools like we heard from Suchi with Bayesian. And yet those alerts probably go off by design in maybe 10% of the patients who show up in the ED who have a syndrome that seems to be a suspected infection, right? They can't go off in everybody. The whole point is to say that most folks are unlikely to have sepsis, so we're not constantly bombarded with false alarms. And yet most of the tools, not all of them, most of them have a positive predictive value of somewhere between 30 and 50%, right? So maybe we're pretty good at spotting the 5% of this kind of overall population of suspected infection that is pretty clearly sick today, and getting them into this care that we know works, which is, the rapid antibiotics, the rapid resuscitation, the protocolized care to make sure that those folks are really taken care of and go on to better outcomes. As a provider, my problem when I used to see patients in the emergency department was most of them don't come in with sepsis labeled on the forehead. And in fact, most of them probably aren't really critically ill. Some are. Some folks are what we like to call the sneaky sick, right? Somebody who looks sort of okay today. Maybe they have a cough and a fever or a rash with tachycardia, but is going to go on to be critically ill tomorrow if we leave them untreated. And we have to pick those out while also finding the correct next steps for the patients that just aren't critically ill, but still have something that they need. They come in with a bacterial infection that needs antibiotics, and it's not sepsis, but if we miss those antibiotics, they could get much, much sicker tomorrow. Or they have something non-infectious, and we have to quickly rule out that we shouldn't be flooding that patient with fluids because we're going to put them into, fluid overload for the heart attack that they actually came in for. And so really, Inflammatix was founded to try to drive outcomes, not in the patients with obvious sepsis, but sort of in the other 95%, where if we can streamline workups and get folks to the right level of care, that's a big benefit for them no matter what. And of course, along the way, we want to make sure that we can spot those sneaky sick patients and get them very quickly sort of into upgraded levels of care. And I think a big part of this for me was that tools that sort of focus on, there's sepsis or not. Well, if I called up a fellow provider and said, "Hey, Dr. Smith, the guy in bed 6 has not sepsis." Okay, I'm not sure what to do with that. The reality is not sepsis could be a lot of things. Not sepsis could mean it's not sepsis, but it's still severe pancreatitis and the patient needs to go to the ICU. Or not sepsis could mean, well, he has a bacterial infection, it's just not sepsis, and he needs antibiotics and go home. Or it could be, this is actually something else entirely, right? And we should be on a different part of the differential. And so really the idea was, let's try to find better ways to drive outcomes across all patients. And in that way, we can also drive better outcomes in those sepsis patients. So there's a whole new generation of tools that look at the host inflammatory response, and we're one of them. We look at patterns of activation in white blood cells. you have a pneumonia deep down in the lungs. You have some bacteria swimming around. That's a bacterial infection. Well, the reason a patient with a pneumonia presents to the emergency department is not, they don't come in and say, I have pneumonia. They say, I have a productive cough, I have a fever, I have joint pains, I have muscle aches. All of these things are signs and symptoms of inflammation. And it turns out that white blood cells react very differently to bacteria on the one hand, or viruses on the other, or even to non-infectious things like blood clots. And by reading patterns of gene expression, sort of how the cells are reacting, we can use pattern recognition to then produce information about whether this represents an infection or something non-infectious, or the type of infection. Is it bacterial or viral? Or how sick is this patient likely to become? We turned all of this into a test that we called TriVerity. TriVerity was granted clearance by the FDA earlier this year, but also got a breakthrough device designation a couple of years ago for being the first and only test to provide an all-cause risk score of the need for ICU level care in the coming 7 days. And we published a lot of patient data, 1,200 patient, 22 hospital study in Nature Medicine, showing that the test works pretty well. But perhaps more importantly than going through a lot of dense clinical data, I'll just sort of talk to you about what it's meant to do. TriVerity is called TriVerity because there are 3 scores. And I think this is really where we begin to get to Orla's question. The test produces one score that says, is there a bacterial infection with a high score near 50 or not with a score near 0? And a separate score that says, is there a viral infection, high score near 50 or not near 0? Now, some patients can be co-infected, right? You could have a high bacterial, high viral co-infection, or much more commonly, we can say, well, this is non-bacterial, non-viral, you should be doing something else. But, imagine that you have somebody where the thought is this is a viral infection. Well, actually, we might be able to say, actually, this is non-viral and is very likely bacterial. You need to be thinking about antibiotics here. Now, diagnosis is important, but it also is critical to know how sick a patient is. And so we have this third illness severity score, which is an all-cause risk score. What is the risk from any cause that a patient in the intended use population is going to go on to receive vasopressors, be on mechanical ventilation, or receive renal replacement over the next 7 days? And so I think to the question asked, well, we don't know, right? And I hesitate to say, but in a case where somebody comes in, and we think, oh, maybe this is a mild viral infection. Maybe we can identify it as, today this is a bacterial infection that needs treatment. It's not viral, but maybe it's not even severe. Maybe that patient today isn't likely to go to the ICU, and you can give them oral antibiotics and send them home and prevent them from being septic tomorrow. At the same time, we had a case recently at one of our hospitals. A gentleman came in his 60s. He was short of breath, febrile. They started working him up for pneumonia. And the TriVerity test came back as low bacterial, low viral, and very high severity. And they thought, that's strange. We thought this was an infection. They decided to broaden the workup and sent an EKG and a troponin. And it turned out he was having an unusual presentation of a heart attack. And so rather than flooding him with antibiotics and fluids, they got him into the cardiac care unit, and he had a good outcome. So, again, not sepsis can mean a lot of different things. And the goal really is to ultimately drive improved outcomes. Not just patient outcomes like spotting infections early, which is important. And we've shown with TriVerity that is much better accuracy than things like white blood cells or procalcitonin or lactate at driving infection diagnosis, but also really in improving operational outcomes across the hospital. Because as much as we might want tools that are better than infection to be standard of care, the reality is if we can't convince a hospital to onboard the test, if it doesn't make operational and financial sense, it also won't go anywhere. So I'll just show you one or two pieces of data from some recent implementations. One of the things that we're most proud of is this point about unnecessary admissions. All right, what we want to do in the end is get a tool that really makes a difference to hospitals. And one of the things we constantly hear is, hey, our emergency department is totally overcrowded. We admit a lot of people for IV antibiotics that may not need it. Maybe we could get some of those patients cared for at home, which is a great patient-centered outcome and can save a hospital a lot of money. And what we've shown is that across a number of different sites now, rural or urban sites, in academic systems or health systems or community systems, in large, IRB controlled studies and in small pilots, we can routinely show a drop in direct admissions from the emergency department in a safe manner. So what I mean by that is, we can look and say, hey, there can be 6 to 10, sometimes 11% more discharges from the emergency department. But we can also show that those discharges are coming with a reduction in bounce backs and a reduction in overall ED length of stay. So it's a very helpful thing for a hospital system overall. And of course, that can also be accompanied by things like a drop in the ordering of other diagnostics that may be unneeded, or a reduction in unnecessary antibiotics. I'll wrap up by saying this. I think in the end, as a former clinician, I always wanted a tool that would match my needs. And when I thought about seeing a patient in the emergency department, a sepsis versus not test, it can be helpful, especially if it happens to be positive. And yet, really, when I see somebody, again, with a cough and a fever, I'm not thinking just sepsis versus not. There's a lot of things that I have to rule out, of which sepsis is one. And in the end, the way to drive implementation of tools, as we heard in the last panel, is really to get something that makes sense to a provider that's answering a real question, like, hey, where's this patient going? And I think the way to do that is to answer with holistic solutions for these folks. So I look forward to the rest of the panel. Thank you very much.